All right, I believe we can start. It's 7:03. So good evening once again. Pleasure to have you all in this edition of the webinar, a learning series. Today, we are the host, we're supporting the host. We are Medlynks. So allow me to do a brief presentation, and then we shall go straight into the updates on HPV testing for cervical cancer screening. So Medlynks, we are an organization who is a collaboration between a medical center and a specialized diagnostic lab. And our mission is to deliver healthcare in Africa where and when necessary. And our vision is to enhance the longevity of lives in Africa. We're looking at how we can improve the lifespan of people in Africa. And we're in Kenya. We've been here for quite a long time, around 5 years. And I believe most of you or many of you have known us or sent patients to us. So today we're just reiterating the message that we are your best partner for all your obstetrics and gynecological tests. And of course, just as a reminder, we are at Landmark Plaza, just opposite Nairobi Hospital on the first floor. So quite in Upper Hill, so quite near a lot of doctors. In terms of our medical labs, well, we cover from a wide range of tests, from routine tests all the way to molecular tests. And more importantly, we are accredited under ISO 15189. I believe this is one of those achievements that not every facility, not every lab has. So we can assure a very high quality kind of testing. And our clinics cover a wide range of services from diagnostics to treatment. The arm that we want to reiterate in this meeting today is more of the diagnosis, because we, like I said, we offer specialized tests and also as a routine lab test. Secondly, we also offer home and office collections. And I know that you may be thinking, sometimes you may have patients who are not able to leave the comfort of their homes, or maybe who are in between flights, or for one reason or another, they are not able to come directly to you for tests. We can actually collect samples and process their sample or the test that you as the doctor will require at their convenience. So this is some of the value additions that we offer. So our medical lab is class F, which is among the highest in the classification of the board. And like I said, we are currently accredited for ISO 15189. So just in summary, we offer a very wide range of tests, including both the routine tests and also the specialized tests. And you can also see here the turnaround time for tests. Should you want to receive a test from us, you can see we do all this, including the star of the show today, which is the HPV genotyping, and both the quantitative and the qualitative. And we can offer this within with a turnaround time of between 24 to 48 hours. We also do other tests, including HIV RNA, HIV DNA, and we can guarantee you in terms of a turnaround time and the quality of the testing that we do. And of course, we pride ourselves in being among the best in terms of testing, such as molecular tests, including COVID and others. And lastly, we also do other tests such as hepatitis B, TORCH PCR, STI multiplex. So basically, what I would say in terms of diagnosis, we are a one-stop shop with assured quality and with a good turnaround time. I think this will help you in terms of your patients accessing care at your facility. And just briefly on the routine tests, we do a lot of hematology biochemistry tests as usual, disease-specific tests such as diabetes, cardiac markers, tumor markers, infectious diseases, autoimmune diseases, hormonal profiles, which I know would be very important for gynecologists especially, and obstetricians in this in the kind of patients that you see. Iron studies, of course, very important, and as well as pathology, where we're looking at cytology and histology. We do these kinds of tests, as well as fluid analysis, for example, for CSF analysis. I know that this would be important, especially for pregnant and expecting mothers. So We do offer a lot of packages, but I'm just highlighting a few here for your convenience, because sometimes you may want to do a wide range of tests, and you also want somewhere or a specific lab where you can get quality, but also at a good price. I'm highlighting here the ANC package, which you can receive for 7,000 shillings. And it entails the full hemogram, blood group, hepatitis, VDRL, HIV antibody, random blood sugar, and urinalysis, all in one package. And then secondly, of course, the female wellness package, as you can see outlined here, including pap smear for just 11,000 shillings. And we can also customize packages based on the specific needs that you may have. I know that STIs are also important for you as doctors. So we do offer molecular tests such as HIV molecular biology tests at 6,000 shillings, which is more accurate than HIV ELISA. But we also do HIV ELISA at 1,500. So you can be sure, and your patients can be sure of the diagnosis once they reach out to us. And we have various packages, the bronze, silver, gold, platinum, as highlighted here. So please, if you're interested, you may feel free to take our contact and also share it at the end of our presentation. So today, just before we get into the talk, we have noticed, and it's part of the guidelines now, that the HPV DNA test is one of the highest sensitivity tests in terms of screening for cervical cancer. And we see that it is higher than conventional pap smear for around 92.1% versus 40.2%. We do offer this test at our facility, and we said that the turnaround time is between 24 to 48 hours for the patient to be able to receive their test. And this is our location. Like I mentioned, we're just at Landmark Plaza, opposite Nairobi Hospital, on the first floor. You will find us every weekday, 8 a.m. to 8 p.m. So I believe this will support those consultations where a patient will see you later, for example, later than 5 or 6, and including Saturdays, Sundays, and public holidays. We are open. So in case you might have a patient who would like to do tests on those days, we are open from 8 to 5. And our location is here, first floor, Landmark Plaza. Our contacts are here, so please feel free to take a screenshot, and I'll also be sharing the contact in the chat as we proceed. So today, to start us off in this meeting, I'd like to invite one of our key doctors today, who's going to take us through this topic of HPV, updates in HPV testing. And this is Dr. Demetrius Mududa. He's a gynecologist and a management expert with keen interest in cervical cancer screening and colposcopy. Ladies and gentlemen, please welcome Dr. Demetrius Mududa. Dr. Mududa, can you hear us?
Yes, I can hear you. Can you hear me?
Yes, you can hear you so well. Please proceed. Let me just stop sharing.
All right.
Go ahead.
Thank you. All right. All right. Okay. Kindly confirm to me whether you can hear me and you can see my screen.
Both are very clear, Dr. Please proceed.
Okay. So thank you for that introduction, Abednego. And today we're going to be tackling HPV testing, as you've rightfully stated. And I think it will be more of a refresher course, but also just to remind us of one or two things that probably can be helpful, so that we can be able to manage the women that we see, and to ensure that we can be able to deal with this scourge of cervical cancer. So one of the preventative measures that we have, that is screening. And so that will be the outline of our talk today. So we're just going to look a little bit on the HPV genome and remind ourselves of a little bit of science. Then we'll tackle a bit on the sampling procedure, compare the HPV test and pap smear in terms of the studies that are out there, and then we'll discuss a bit on the screening schedule. So I know this is some of the issues that I think when we used to look at it when you were in school, you get a little bit of headache, but I'll just break it down in simple terms. Let me just minimize that. That's the HPV genome, and typically it's spherical in nature and has these proteins that are labeled right there. But in simplicity, the E proteins are what the virus expresses early in differentiation. And of note from the E proteins, the major ones in our talk today will be the E6 and E7 gene that is actually involved in what we call cell immortalization through affecting P53 and retinoblastoma genes. And when it does this, it disrupts the cell cycle, thus causing what's called a vicious cycle into what can cause precancerous lesions and later on invasive cancer. Then of note, we have the late genes, which are the L1 and L2. And this specifically is what causes the shell, the shell of the virus. And its function is to be able to penetrate the epithelium once an infection occurs. So in a nutshell, this is how the HPV genome looks like. Just to remind us on the types of HPV, there are several of them, but the ones that I've highlighted are the high-risk types that are responsible for precancerous lesions and invasive cancer. And, 1618 are the commonest. And, in the testing that is there, what Abednego has shown us, 16 and 18 would be picked. And a couple of them also, if you get the 14 type PCR technology, you'll be able to pick majority of these. But those are the common ones that cause invasive cancer. So how does HPV cause an infection leading to cervical cancer? So just a quick reminder is that the picture that I've shown you is there'll be a break in epithelium, okay? And, this is at the cervical level. And once that occurs, the HPV will go to the basal area and be able to cause an infection. And through that, get into the cellular level and starts replication of DNA. So once the acquisition of the HPV occurs, majority of this infection will be cleared. And, this is usually within 1 to 2 years, it will be cleared. And if there's some factors that help the clearance, if a patient is young, but there's a small percentage that will persist and progress to precancerous lesion. So age comes into play. Immunity comes also into play. If you have issues like HIV, diabetes, this can lead to progression. And once that occurs, and you have precancerous lesions, it's just a small majority of them that will go ahead and invade the cervix and thereby cause cancer. So that's the process and steps of cervical cancer, from infection to basically cancer in itself. So I put this slide just for us to be able to familiarize ourselves with the technology that is available when you order a HPV test. So majority of the tests that are present are actually DNA tests. So the commonest ones will be hybrid capture and the KOGS system. And how these work is basically on amplification of the DNA material. But there are newer technologies that came in, and these are RNA tests. And, there's been an argument, which one is more superior? Is DNA better than RNA, or is the new kid in the block RNA tests more superior? We'll have a look at some studies just to be able to just answer that question. But just to mention, I think this is what Medlynks uses as their test kit for HPV test. So the kit picks 14 genotypes, which are outlined there, and 1618, which is the commonest, will actually be reported by this kit. And with that, I will want to just compare the DNA test and the mRNA. So there's a study. This is a study that I had a look at, and it was an observational study between 2016 and 2018, and they were screening patients between 25 to 60 years in 30 locations. So in total, this study had 13,000 women, and they wanted to see which test performs better. And it was interesting that mRNA, which was considered less inferior because it picks specific proteins, and most of the time this is the E6 and E7. It's not like the HPV DNA that will amplify most of the viral particles. So the sensitivity was the same, and in fact, it was shown to have a higher specificity than the HPV DNA. So that said, I think it would be arguable if you told about a technology and you're really interested in what test is actually performing this screening, whether it is an mRNA test or a DNA test, you can't be assured of test accuracy. And by so, the WHO in 2021, actually recommended HPV DNA over mRNA, but they made a proviso that in case you do an mRNA, you should be able to follow up these women regularly at 5 years. So I'll move on to sampling, because this is something that I think we just need to be able to be on the same page and make a refresher on. So the sampling can be done in two ways. You can do either allow the client to do a self-collection, or I think more commonly, we can do the collection ourselves as a healthcare providers. So how is this done? So there's some specific testing kits that are available for HPV, which have brushes. And if the sample will take time to reach the lab, and probably Abednego will mention how long can it take for this sample to arrive so that it is still viable, you can send this to the lab and it will be run. From my experience, what I've done, and this is if the sample reaches the lab at least within a couple of hours, which they normally tell me around 12 hours, if you use the normal cyto brush to do a pap smear and you do your smear, you can use the same brush and you cut it off and leave it probably in a urine container or a stool container. And once they take that, the lab will be able to process it from the epithelial cells that are there. And when you're doing the test, ensure that there's no mucus or the excess. Just wipe away the mucus, because the cells themselves will help so that we end up not getting false negatives. I think it is important to show that this is actually our national cancer screening guidelines, and I must congratulate the authors of this document. It's a very nice document, quite nice to the eye, a lot of details, and it's important to show that self-collection is actually recommended by our Ministry of Health. So the question can be, from self-collection and collection by a clinician, which one is superior in terms of, picking scene 2+ and above? Are they comparable? And the studies that have been done. This study was done in the Netherlands, called the IMPROVE study, and they're checking a population of the ages were 29 to 61 years. So it was a non-inferiority trial. And in both of these arms, almost 8,000 patients. And it was seen that there was no difference in sensitivity and specificity between doing a self-sample and going ahead and doing a clinician-based sample. So I think, I think we'll wait for reactions, but from my experience, for ladies who are afraid of pap smears, the reasons they've given me is, one, they are ashamed to come in and and expose themselves, or they just don't want to know that they have cancer when they do a pap smear. I think this can be an alternative in practice for such kind of patients, to be able to just allow them to do a self-test. So long as they follow instructions, this is good enough for cervical cancer screening. So this question here is, put this in just to show, this was also, we have data in sub-Saharan Africa, and Kenya was one of them where this meta-analysis was done. And so a meta-analysis of RCTs, and it was still looking at self-sampling. And the conclusion was it's an effective and feasible alternative to clinician-based sampling. And the interesting bit, although the data was a bit heterogeneous, they found that the uptick was higher in terms of screening for women who did self-sampling than clinician sampling. I think it's important to also just do a comparison between HPV test and pap smear, because a lot of guidelines have changed, in fact, in the West, and not just the West, even our own guidelines concerning primary care screening. And the one to HPV, the primary pap smear, this is dense. In short, HPV is more sensitive to do pap smears. Of course, there's reason for the fact, some look at the pap, you give two pathologies. I don't know whether some have experiences. You have someone reports as normal, someone else reports it as HCl. This is the kind of sensitivity we're talking about. So the HPV test will likely miss less cases of SIN2 and SIN3+. Although it might make you refer more patients, I think it would be better to pick patients who are likely to get SIN2, 3+, because as precancerous lesions that are high grade, these are the people we want to pick. And of course, if you get a negative HPV test, it's reassuring than a negative cytological test. And again, it's just about the predictivity value. So of course, I'll say this was done in 2018. This review had 140,000 women involved, screened between 20 years to 70 years. So this is the WHO 2021 recommendation, and just put this up just to remind ourselves on the screening approaches that are available to us. So today we are just concentrating on the molecular side and HPV testing, but still, if cytology is what is available, yes, we go ahead and we do it. The important thing about liquid-based cytology is that you can be able to pick both the smear itself, but you can also be able to do an HPV test on liquid-based cytology. And I think via villi is very important, especially in settings whereby we do not have the requisite resources. So we move to screening schedule, and I just want to mention about this recommendation that was made by this task force. And I've highlighted what the screening schedule is. So they recommend that women above 30 years should have HPV testing. Now, why not below 30? The reason for this is that, it's the clearance of the virus when you're young is quite high. So sometimes if you screen, you get a negative, you might miss any issue with the cervix itself. So the recommendation is for this specific task force was above 30 and 5 years. So you can actually do the HPV testing 5 years apart. But if you decide to do cytology, then a 3-year screening is acceptable. Now I'll leave it maybe for comments and reactions concerning annual screening, probably at the end of the presentation. So for the American Cancer Society, again, they revised even the age for start of screening. So for a long time, we've been saying anyone above 21 years, you can start doing pap smears or screening every 3 years. But again, these are just paps. For them, they put HPV at 25 years, revising that age from 30 only and below. And again, the schedule should be 5 years apart, and that's what is acceptable. In practice, I think what I've adopted is I feel that if the resources allow, and if you can be able to in your practice do a pap smear, I think it's added value if you can also have a pap smear and do a core test. And so that's acceptable. But in a situation where you can't have both, the screening schedule should be there. Women above 65 years and who've had normal pap smears before, so I'm talking about 3 pap smears in some guidelines that have been normal, then you do not need to screen such women who are above 65 years. So I think today's talk, I will conclude it by looking at our own local guidelines. And it's important just to see what is mentioned. So who should be screened? And these local guidelines were published in 2018. They're free source in the Ministry of Health guidelines. The target population is 25 to 29 years. So anyone above 25 should start screening. The provision is this. This depends with someone's sexual history. If someone has multiple sexual partners or started sex quite early, it's given, you take a case-to-case scenario and you can be able to start these screenings earlier. And you can see that recommendation is a 5-year screening. And the HPV test is given as the primary mode. For us, we are still putting it at 30 years. If you want to revise it down to 25, it's okay. But those are the recommendation. But key point here is the role of HPV testing as the primary screening method. So I'll leave this algorithm just to be able to show the pathway, just in case a lady has an HPV test and it comes back as positive. And for high-grade, high-risk types, then recommendation is to go for colposcopy. And if you go for colposcopy, you can go down now the algorithm based on what you see in terms of treatment and availability of the treatment modality. So just leave that for a couple of seconds, but can share this later on. Yeah, so that was my presentation. Just wanted to give updates on HPV testing, and if there's any reactions or any questions, I can willing to take them. Thank you.
Thank you very much, Dr. Mududa, for such an elaborate presentation. Well, can give our virtual claps. In the meantime, I think we can, for those with questions, you can start typing them in the comments, in the chat section. Thank you. I can see the claps. For those with questions, please type them in the chat. And for those, with comments, I think please type them in the chat and then we can proceed. For those with comments, you can unmute for a comment, 1 or 2 comments before we get into the questions. Thank you.
Thank you so much. I'd like to comment. Is Edmond?
Karibu Edmond, go ahead.
Yes. So that was an insightful presentation. You've touched on both self-collection and also the HPV testing types. So I'm concerned on the low resource settings and also triaging, so that we don't bombard hospitals or the high-end hospitals with maybe women who just want to screen. So it's better for high-end hospitals to receive only those cases which can be handled, maybe for treatment. So for self-collection, yes, the Netherlands study showed very well that the clinician collected sampling and the self-collected sampling gave reproducible results in terms of the integrity of the sample collected. So that is why I think it will be good to extend also the self-collection so that we encourage women to screen, because the main challenge has been women fearing to be examined. They fear the fact that if a colleague or maybe is examining, of course, they fear that. So they prefer to self-collect. So the self-collection actually, as per the even WHO, is the key thing to encourage women to test, even if it means scaling up to even low resource settings. So, and then now for the technology, you've talked about both the mRNA and the DNA technology, and seeming like it is the in terms of that study which you indicated, it has the same kind of outcomes. But then now, yeah, I think for the mRNA, it needs to come out because of the oncoprotein, the fact that it's able to detect for the E6, E7 oncoprotein expression, and those are the specific biomarkers for oncogenic activity. So I don't know if you are going to say that it can be, it's kind of like, is it superior or not? You respond to that, because it can, with this high specificity, of course, it's a no-brainer. Detection of the E6, E7 will guarantee high specificity, yes. So then now for the many women over unscreened and underscreened women, I think it will be good to maybe have technology like the new technology, the new entrance in the market, the rapid testing that can be scaled up to low resource settings to target the unscreened and the underscreened women. So if we sort out the issues of loss to follow-up, because one of the findings is that to sort out issues of loss to follow-up, which studies are showing, we are talking about 40 to even going up to 60% loss to follow-up, then the solution is to minimize the turnaround time, so that we capture that woman who has been primed to screen, then we communicate the results on the spot. So with the new rapid test, I think it can be a good technology to appreciate. So that we sort out the issues of turnaround time. So the other thing is about the women to screen. You've talked about 25 to 49 years. So I don't know if we are going now to scale down to 25 years. But you've talked about it depends on the history. So, but yeah, I think studies are showing that women or ladies are engaging actually in sex as low 9 years. That is why vaccination has gone down to around 9 years. So I think we can actually have a conversation about that, so that if it means scaling down to 25 years to have the screening, then we can go for that. So thank you so much. Yeah, thank you. I think we'll still have a conversation.
Yeah, thank you for those really great comments. I think there are quite a good number. Dr. Mududa, if you could respond. In the meantime, please keep sending your questions and comments as well to the chat.
Okay, thanks Edmond for your comments. I think you know, you have echoed quite well what we've discussed today, and I think the question of low resource settings is a big one. And I think, as you said, the advantageous angle of self-testing is that, you know, these patients who cannot be gotten and brought to the healthcare facility, if they can be able to do this testing themselves and drop them off to a facility for testing, I think that is the way to go reduce the scourge of CS cervix. In terms of superiority of mRNA and DNA, so DNA is what is recommended right now. Even if you look at FDA approved tests, it's DNA. So the mRNA, as you said, it's E6, E7, is quite specific in picking HPV. But of course, for a screening tool, you want something that is quite sensitive and of course specific. So as more studies come out, I guess with time, because it's easier and faster, even the turnaround time for mRNA is faster to be able to go to mRNA HPV tests. And I think I'll address a low resource setting by also answering Josephine's questions, which is HPV testing cost effective and sustainable in the public sector? How do we sell this to the county governments to budget the kits? So I looked for studies on financing, but especially economic evaluation for such a screening policy. And unfortunately, we don't have anything published in Kenya. Even in the Ministry of Health documents, I didn't see an economic evaluation for HPV testing. But there's some that have been done. I saw an India study. The reason I didn't put them, they were not looking quite relevant to our situation. I also saw one in South Africa and also one in UK. And these were trying to look at the cost effectiveness of HPV testing vis-a-vis the whole pathway, vaccination, referral for colposcopy, treatment. And it was actually found to be cost effective in terms of increasing quality of life adjusted years per 100,000 women, those studies. And one of the studies was looking at incremental cost effectiveness ratio. And this was actually better with HPV testing. So my challenge probably is for policymakers and where the tests are being done, if we could be able to do an economic evaluation, then this can be convincing to the public sector that it is cost effective. I think maybe Abednego will tell us how much it costs at CA Medlynks for those who are in practice. Moshe asked, is co-testing superior to HPV testing alone? I think in terms of such a study, you'll be doing an inferiority study. But when you look at this, you're already taking a pap smear and HPV. So it will be very difficult to compare that with HPV alone. But I would say that does pap smear add more value to your advice and management of the patient? It can. It actually can. And so, if you can be able to do core testing, then at practice level, you can go ahead. But in terms of the cost, it will be higher. And will it add more value than just deciding to do a HPV test? Because remember, if you do a HPV test and it comes positive for high risk, then the next step should be colposcopy. All right. You really don't need to do a pap smear now to decide that, what do I go for colposcopy or not? But of course, if you do testing, and I've not yet found, because I do a lot of colposcopies, I've not seen a patient who has a precancerous lesion and the HPV has gone negative. Most of the time you find that it is positive. But of course, if you do a pap smear and your HPV is positive and you have a high-grade lesion, you'll even skip the pathway sometimes for colposcopy and go straight on, depending on the patient characteristics, and go for a lip procedure or cryotherapy, depending on the setting. Thank
you. Thank you, Dr. Mududa. Very well articulated. Any more comments? Please feel free to unmute, and the questions you may continue to post them in the chat.
I ask a question or make a comment?
Go ahead, Dr.
Yeah, my challenge has been, or sometimes I'm in difficulty making a decision based on HPV DNA, mainly because the results we receive, they are not typed, they are not specific. They just report HPV DNA positive. So I think moving forward, we should be able to type them, because it's good to know whether the patient has the high risk type or other types. And this can sort of help us make a decision. And I hope what is being discussed here can give us the specific type of the DNA that the patient has. Thank you.
Thank you, Dr. Ali, for that great comment. Let me just respond to a question around the cost of the HPV testing in our facility and the genotyping. At our facility at Medlynks, we do a HPV genotyping, which will cost 10,000 shillings. So we can be able to tell you which particular genotype is affecting. And I think, to add to your comment, Dr. Ali, that really helps in finding out what exactly is happening with this patient. But we are also able to do just the DNA PCR test, which costs 8,000 shillings. So I would say we are in the market, we are quite competitively priced compared to other similar categorized labs in the facility in Nairobi. I think there's another question, Dr. Ali, on the chat as we wait for more comments. And it says that there's an entrance in Kenya Mobilab mRNA oncoprotein HPV rapid test device offered by Mobilab. So it's about sort of a rapid test, and in 15 minutes it would be able to give you the result. And of course, could be cost effective, especially where you're talking about low grade or low resource settings. Maybe a comment from Dr. Ali and from the team as well.
I think, you know, when you talk about molecular tests that look at antibodies, they are readily welcomed once you look at studies concerning it. I can say honestly, I haven't looked at this in terms of an RCT and how it performs with the specific numbers. But generally, you know, if you want to roll out this on a national level, then, you know, such technology will be welcomed, especially in low resource settings. And for Dr. Eli, mine is just to thank him for his comment. Thank you for that, Dr. Eli.
All right, thank you, Dr. Eli. Any other comments? Okay, it seems there are no more comments. So allow me to just reiterate a few elements around some of the questions that were asked and a few of the comments. So as Medlynks, we want to be your partner for all your diagnostic testing. And as we discussed here, I've already mentioned around HPV testing, both the genotyping and the DNA PCR are available at our facility. Well, we also do the other routine tests. So you're very welcome to send in your patients, and our contacts are here as indicated. We are at Landmark Plaza, just opposite Nairobi Hospital on the first floor. And we will, of course, give you high quality tests at an affordable price. There was a question or a comment around samples. If there is for example, in your setup where you'd like us to come in and pick a sample from your clinic, we do offer that service, and especially at your clinic or at your office, we will do it for free. And usually all the samples reach our facility within 1 hour. So you can be assured that the integrity of the sample will be maintained. And of course, now that there is talk of self-collection of the sample for HPV testing, I think we're moving into the next level. And this, of course, will help in terms of taking care of our patients much better. I would also add, just briefly say that a lot of the molecular tests that, for example, what we discussed today and more are available at our facility. And our turnaround time is between 24 to 48 hours as listed here. So you can be rest assured that we'll be able to give you a test at within a good time period. And just to add, we also do the normal routine tests, including the packages, like I mentioned, because usually for pregnancy, for hormonal profiles, there's a lot that you may want to check for as a doctor. You can be able to customize the package or give you the package at a good rate. And we do all this, including pathology, fluid analysis, such as CSF analysis, the iron studies as well, disease-specific tests, because I know that some of you are managing or co-managing patients who may also have, for example, diabetes or have some cardiac issues, as well as infectious diseases, autoimmune disease, and even sometimes allergies. So we can be able to cover your patient completely in all these different testing areas. And this is just an example of the packages that we can offer for A and C for 7,000 shillings, quite competitively. And for female wellness, as you can see, we will do the entire range, including renal profile, lipid function, lipid profile, liver function, HbA1c, urinalysis, and pap smears as well, just for 11,000 shillings. Our facilities are accredited by insurances, so your patients can be free to come to a facility and we'll take care of their specific needs. Then lastly, in terms of HIV tests, which I know are very important in your setup as well, we do HIV ELISA tests for 1,500 shillings, and the molecular biology tests, the PCR tests for HIV for 6,000 shillings. And we do have various packages. Sometimes we do get patients who would like to come in and do the full package that has chlamydia, gonorrhea, HSV, and including HIV, VDRL, and hepatitis. We offer that as a platinum package for 16,000. And we do offer the gold package that has chlamydia, gonorrhea, trichomonas, HSV1, 2, and the urine routine for 16,000. The silver package includes the chlamydia and gonorrhea for 9,000, and as well HIV ELISA, VDRL, and hepatitis for 4,000 shillings, which is the bronze package. So basically today we want to be your partner or your preferred partner for all the diagnostic testing, and our contacts are here. I'll be able to share them as well in the chat, but please feel free to reach out to us. We have the advantage of working or offering our services to you and your patients on Saturdays, Sundays, and public holidays, 8 a.m. to 5 p.m. But on weekdays, we are available Monday to Friday, 8 a.m. to 8 p.m. And of course, we'd like to be your best partner for all your diagnostic services. So allow me to invite Dr. Mududa just for any closing comments, and then I will close the presentations. Thank you.
Okay. I think mine is to make a point that for all of us in practice and as colleagues, let us screen. Let's not have the excuse not to screen patients. And let us also give our patients the information that is out there that, you know, if they feel that they want to, they can do self-testing. And I guess if all of us just advocate for this, I think cervical cancer will be kicked out of our country like polio. Thank you.
Thank you, Dr. Mududa. Indeed, we hope to be able to kick it out like polio. And more importantly, we can be able to get a quick diagnosis, especially in early stages, and be able to take care of these patients. With that, let me say a big thank you to all for attending our webinar series on HPV testing. We hope it has been a an invaluable session for you in terms of your time. It's been valuable, and we hope as a healthcare provider to be able to support you as a doctor, as a pharmacist, as a nurse, to deliver great care to your patients. Thank you very much, and I do wish you a nice evening. Asante.